Though we use external fixator in our daily emergency orthopedic practice, but during our residentship, we are not confident enough about the all mechanism of external fixator. And so I think this PPT presentation hopefully help our resident for doing their best job at our emergency services. External fixator is a device which will place outside of the skin that will stabilize the bone fragment, as well as it will help for give the chance for soft tissue healing, and sometimes it also help for formation of a soft callus over the fracture site. Along with it will help some plastic surgery intervention. Now regarding the external fixator pin, there is a rule is called near and far concept. Now, if we get stability over this fracture site, we have to put first pin as near as possible to the fracture. Then the second pin will have to put as far as possible from the fracture side. Okay. Now regarding the biomechanics of external fixator, there is two terms. It's called radial preloading, one is axial preloading, and you have to know the distance from the bone to the rod. Now these are, suppose these are the pin, and minimum 2 pin is necessary for stability. If we can get 3 pin in a single cortex, that will give more stability, but 2 pin is minimum requirement. And the distance from this bone to up to the first rod proximal to the bone or parallel to the bone, the distance from the bone to this the rod, it will be very much very adequate if a 2 finger can pass, because it will help for dressing of the wound. Along with it, as close as the bone, it will increase the chance of stability also. But if we put this very close to the bone, then we cannot do proper dressing, or after application we cannot stitch the wound, so or any plastic surgery intervention will be very difficult. So at least 2 finger breadth distance from the skin border, or from the skin, that is necessary for application of the rod. Now what is radial preloading? Radial preloading means when we are putting the pin over the bone, then if we do undersize drill, then that rod or the pin, when inserted into the bone, that will give a radial pressure over the bone. Then anchoring effect of the bone of the pin will be very high, so the chance of loosening will be very less, and the stability will be very high. So this is called radial preloading. And sometimes we can do axial loading also. Means after putting this pin, we can compress this proximal 2 pin in the fracture site, and for distal one we can just distract the tip of the pin some extent, and we will tighten up the euro clamp. It will help to do a good alignment, as well as it will give more stability, as well as it can give a compression of the fracture site also. So this is called axial loading, and this is called radial preloading. But this radial preloading is mandatory for a proper external fixator. This axial loading is not necessary. Now there are two type of construct. One, we can reduce the fracture, then we can put the pin parallelly, and we will put one external fixator rod. But when this fracture is not totally open, suppose there is open wound, the fracture is not open, so in that case, if we open the fracture site, that will may contaminate this this zone. So in that case we can put two pin here, two pin there, then we will put two inter rod. After that, under siam we will manipulate it and we will put a interconnected rod. That is more biological. Now this cannot be done all time. If we get already open wound like 3B, then this type of construct is not necessary. But in type 2 wound or type 3 wound, and the wound is not, the fracture site is not open, in that case this construct is good. And after this one rod fixation, if we put another rod, this is called mirror fixation. It will increase more it will give more stability to this fracture. And alignment is very important. Under siam you must check the alignment and rotation of the limb. It will help for soft tissue healing, and in the long term when we will remove this X-fix and for putting a nail, that will be more easier. So you have to take care of that. Now there are many type of construct of the X-fix, like uniplanar. This is called uniplanar, and this is the mirror, and this is called biplanar. In case of child we can use this, and we have to spare the joint line and the physis. And another is spanning X-fix. In case of ankle there is a comminuted fracture, we can span the X-fix. And sometimes we can use delta frame. This is called delta frame. We most commonly use in the elbow and the ankle joint. But maximum stability will keep this biplanar. And there is also a triplanar X-fix, I will show you. But basic concept regarding the X-fix, you have to know some instrument. This is called universal AO clamp. AO I will discuss it after this discussion. Just remember, it is called universal clamp, AO clamp, and this is called open-ended AO clamp, and this is called tube-to-tube AO clamp. That will help to connection one tube to another tube. And this is the AO rod. This is actually cylindrical rod, and this is called sang screw, not pin. And most commonly it is 4.5 millimeter in diameter. Sometimes we can get ancillary pin also, and for metatarsal we can get 2.5 millimeter and 3.5 millimeter pin also. And this is called trocar, where we are dealing with femur or humerus, or there is a huge soft tissue with deep fossa, and skin is bone is not very superficial. In that case, this trocar will help for drilling and insertion of the pin without damage the soft tissue and deep fossa. Okay, this is very important. And this is called T clamp. This is called T clamp. It will help to insert this sang screw, and this threaded part will insert into the bone. And this is TL, and this is spanner. It will help to tighten up the nut. Regarding this cylindrical portion, why this is cylindrical? As per physics is concerned, any stability or any bending force of a cylindrical structure will be very high to deform it. So it will give higher stability, along with it will be very lightweighted. And now the modification is carbon fiber cylinder. Now regarding the all parts, there is a special part. This is called T clamp, that will use for one pin, and this will for another pin. That is most commonly used in the proximal tibia, distal femur, or distal tibia also. And recent modification of AO clamp, that is universal, and that will be very easy for insertion of the pin. And that rod is transferred as a carbon fiber rod, that will be very lightweight, but it is very costly. And regarding the insertion of the pin, you have to know the safe zone. What do you mean by safe zone? For any limb we used to do X fix. Now you have to be very cautious regarding the neurovascular structure of that limb, because whatever we have given in this external fixator operation, we have to put it percutaneously, and you have to a eye estimation where the vessel and nerve can be injured. So to say so we have to put the pin in the safe corridor. Okay, in the proximal tibia there is a huge amount of safe corridor. After the distal after that at the level of tuberosity there will be 180-degree hip corridor, then this is 140-degree, then in the distal tibia again that will increase, and that is governed by the anatomical position of the posterior artery, anterior artery and the peroneal nerve. You have to know each and every level anatomy. Regarding the femur also, thigh bone also, you have to know the shape corridor. Proximal is lateral 1/3, middle is lateral 1/3 up to the anterior portion, and the distal again the lateral 1/3 and the anterior portion also. So you have to know the shape corridor as per cross sectional anatomy, same as humerus even, but in the spiral group you have to be very cautious from the lateral end of from the elbow line, at least lower 1/3 where the radial line is crossing this humerus intermuscular septum, that will be very cautious. And for the spiral group, you have to put the pin from lateral side, not from the posterior aspect. Okay, and for the forearm also there is some cross sectional anatomy, but I just want to give one small information. For the anla, the hip corridor is very high, but for the radius that is very difficult, and for distal radius there the hip corridor is high, but for the proximal radius the hip corridor is very low. Now pin placement have to follow some rule, like most common site of non-union is distal 1/3 of the leg, most common site of dangerous injury here, and most common site of avascular necrosis or avascular problem is here. So avoid this area for pin fixation, and avoid a critical soft tissue neurovascular bundle or joint and tendon which already damaged. And regarding this external fixator, we have at least a basic knowledge about the flap. Flap means that will be done by plastic surgeon. But you have to know from where they will take the flap. So you have to put the axis pin beyond this their territory. Otherwise, they again call you in the OT and they will tell you, please displace it or reapply it. That will be very difficult. And some you have to give some stable fixation. Otherwise, plastic surgeon cannot do his job properly. And there is some modification of external fixator. It is called hybrid external fixator. What is this? This is a half ring of Iliya rope, and you have to put the normal external fixator in the tibia. That is most commonly used in the proximal tibia sciatica type 4, 5, 6 fracture, where there is huge chance of compromission, of huge chance of soft tissue injury, chance of blister is there. So very minimum invasive, we just go for reduction of the articular surface, and we can put the external fixator over the tibia, and we can stabilize is by a delta frame type of XP. This is called hybrid fixation. That can be done in the distal tibia also. Now, regarding the periarticular fracture, this hybrid fixation is very useful, and that will also help for giving early mobilization of the joint, and it also prevent the chance of skin damage and compartment syndrome, and the result is marvelous. For periarticular fracture, we can do spanning aspects. What do you mean by spanning aspects? Suppose there is a fracture around the knee, or it's called floating knee. In that case, you have to give a relative stability on the knee, and sometimes this injury may be associated with knee dislocation or vascular injury. So vascular surgeon have to do their anastomosis or any type of operation. Then you have to stabilize the knee. So this is called knee spanning space or ankle spanning space or elbow spanning space. In that case, most commonly knee, we can put 3 pin over the femur, 3 pin over the tibia, and just interconnect this rod. This is called spanning space. In that case, you have to do at least 15 flexion of the knee, and you have to maintain the palm line. Otherwise, this leg will be deformed. And mm, and during this operation, we can put 2 to 3 gears or pin to restore the articular congruity of the distal femur or proximal tibia. But plate and internal fixation and try to avoid. And when you will get any bad knee injury, knee dislocation or proximal tibia injury such as type 4, and that will reach to your OT at least 6 hours later, then there is a high chance of compartment syndrome of the leg. So prophylactically, after knee spanning space, you better do a prophylactic fasciotomy. That will help for preventing the compartment chance of compartment syndrome in the next day. And you have to counsel and their family member that there is a chance of limb ischemia, so we have to do this operation, extra operation, and that will be managed by plastic surgery after if the limb is salvageable. And also for close fracture, if we get some compartment syndrome like this, then we have to put some XPs and do the fasciotomy. But bone stabilization is very important factor for management of compartment syndrome, which is most commonly found in the both neglected both bone leg fracture. Now there is some pylon fracture. Pylon fracture means distal tibial commuter fracture. In that case, huge soft tissue swelling, bad tissue conditioning. Then you cannot put any implant, maximum KOR. So better to go for knee spanning ankle spanning XPs, and that the skin will be the skin wrinkle will be reduced after this fixation, and it will be normalized easily. And like this is the pylon fracture, and this is the blister, but after this XPs, that will be very easy to manage. And when you can get a fracture blister, generally in the metaphyseal region like distal tibia and proximal tibia, we will get hemorrhagic blister. That means there is a cancellous bone injury. In that case, just we have to puncture this blister. You have to put a sterile dry gauze or gelonate, dried gelonate with mupirocin ointment or neosporin ointment. You have to do daily dressing, and after the experience that will be healed. And if we get any articular incongruity, we can put cover under the CM after ligamentotaxis. Ligamentotaxis means the traction of this pin and this pin. It will help for reduce the articular congruity like distal radius. And some open fracture that needs vascular repair, we can put this XPs we have already shown. Now, what are the advantage of external fixator? So, first, we already told it is a less damage or less blood supply, lead jeopardization of the blood supply to the bone, and this has been done very minimum effort. and this is that will be that can be done very quick surgery. So it is also a armamentarium for damage control orthopedic. I already discussed it before. And regarding the fixation, as this is a temporary fixation, so relative fixation is adequate, and it is a very good option to prevent the infection, and it is very good option for soft tissue healing, and it is a very good option for plastic repair. And uh, regarding the further configuration of X-fix, we can get some pelvis fracture where patient is suffering from hematological instability. In that case, we have to think regarding the flat bone injury. Now, if patient is hemodynamically unstable, we have to check any true pelvis or any blunt trauma injury or any interabdominal injury present or not. You have to call general surgery fellow, and they will do fast technique and or sonar assisted USG, and after that they may call for doing the pelvic X-fix. This is called C clamp. This is called C clamp. Now in the old age we used to put 3 pin along this iliac crest. Then we will put one rod here, one rod here. Then we will do this interconnecting rod. Now to putting this type of pin, we may slip and we can injure the colon, or we can injure the cecum. So better not to put there. You can put this over this supraacetabular area. There is a very huge bone and thick bone, and in the inner aspect there is a huge psoas, iliopsoas muscle. So chance of injury is very less. And in the posterior aspect there will be, or outer aspect there will be huge muscle belly of gluteus muscle. So the chance of injury is very less, and we can use it just below the anterior inferior iliac spine, and we can put 1 to 2 shank screw over there percutaneously, and we can put the C rod. Okay, this is and after this operation you have to call for your general surgery fellow or urology fellow. They will take care of the perineal injury, or if there is any gynecological injury you have to call the gynae fellow also. And remember, the pelvic X-fix is very dangerous. They will give very minimum time, so you have to be expertise enough to do this pelvis X-fix. And when you will reduce this pelvis, you have to check pulse over the arterial dorsalis pedis. Sometimes the internal and the external femoral the external iliac artery may be compressed over this fracture area. In that case you have to explore this area, and you have to call CTBS also. And for this region if we get a chance, we can do CT angio also before going to do any operation. But in our setup that will be very difficult, because in the that can be done only in very high volume center and trauma center. But in our setup you just know how to do X-fix and pelvic X-fix and its recent modification. And before putting this X-fix you have to take care of the patient hemodynamic stability. You have to be assured about the blunt trauma, and you have to take care of the urological part and genitourinary part, like you have to do any suprapubic catheter or any police catheter. And you should not do this operation alone. You have to take care or you have to take help of other fellows. And X-fix also used in ligamentotaxis. It is a certain it used in certain interarticular fracture that can be treated by external fixation using traction by fixator on the capsule and the ligamentous structure around the joint. This work well for commutator interarticular fracture like distal radius and the distal tibia fracture, where the using of plate is very difficult to manage this case. It can this type of fixation is called JS fixation, and this type of fixation called external fixation with traction that will heal this fracture very easily. So I just want to give a revision for what are the indication of X fix: open fracture, the closed fracture with soft tissue complication, periarticular fracture, and for as armamentarium for damage control orthopedics in a case of pelvis fracture, and yes, some pediatric fracture can be managed definitely by external fixator. Now, what are the complications? Most common complication is pintac infection, pintac loosening, neurovascular complication, muscle tendon impairment, delayed non-union, compartment syndrome, rib fracture, limitation of the further operation, and some cosmetic problem along with some joint stiffness and CRPS, chronic regional pain syndrome. Why? Because of ill treatment or ill management or inappropriate physiotherapy and motivation of the patient. Because after external fixator you or any type of operation, you have to do repeat debridement after 48 hours. You have to send the routine culture, you have to do proper dressing, and you have to do ankle movement or knee movement or finger movement along with to prevent foot drop with a sprintage. Each and everything have to take care in the round. So for our first aid resident, you must take care at the ward. And regarding the pin, this is the most common cause of pin tract infection is loose pin. Now we have to be very cautious regarding this pin insertion. You have to give a adequate incision. You can give a cushion incision or you can give star incision, but you have to release the skin properly. Then you have to put the drill, then you have to put the pin. During the drilling you must use some for use soft tissue like femur or humerus. You have to use trocar, or if you are using over this XP over a scene one like tibia, you can put a mosquito for retraction of the skin. And during the drilling we must put some water that will help to prevent the thermal injury. Now for the to prevent this thermal injury, that will also help to prevent the the ring ecosystem around the pin. And I think after this pin insertion we used to put betadine soaked gauze around this pin, but that will be very difficult. That will be because that can cause wound problem. So put a NX soaked gauze only, that will helpful. And from the next stage we can use gentamicin drop, that that will help. Okay, and pin tract care is very important for maintaining a good outcome of the XFix. And sometimes we can use in the pediatric age group, that can be used as a long term fixator or definite fixation. And there is last but not the least, this is not a XFix, this is called AO distractor. What does it mean? There is a pin there, same as screw, that will put in the proximal femur, and that is going to come in the distal femur, by which there is a distractor, and by rotating this the femur will distract. It will help to reduce the fracture fragment, and it will help for maintaining the bony alignment. In that case, by which we can put a plate by MIPO technique, minimum invasive technique, and we can use for osteosynthesis of the femur as well as the proximal tibia we can use. So this is not a external fixation, this is called AO destructor. Okay, I think I have cover all the query regarding external fixer, and but for last two words I again repeat, external fixer must done under observation of a senior, because this external fixer can help that patient for limb salvage, that is very important nowadays.